Hello and welcome to Sleep Review's webinar, Multidisciplinary Perspectives on OSA Treatment with Inspire for CPAP intolerant patients. Today's program goals are identify patients who meet indications for Inspire, prepare a patient to be referred to an ENT for Inspire evaluation, and understand key elements of Inspire post-implant care and management. After the presentations and roundtable, we'll answer your questions. Submit questions anytime via the Q&A box on your screen. We also have the advanced questions submitted on the webinar registration screen. So when we get to the Q&A segment, we'll lead with those. A PDF of the slides are available for your personal use in the handout section on your webinar control panel. This program is brought to you by Inspire. Today's webinar is being recorded, and you'll receive an email tomorrow with a link to the recording. It will also be available for new registrants to watch on GoToWebinar for the next 3 months. I'm now pleased to introduce our 3 presenters. Dr. Maria Cerna is an assistant professor in the Department of Otolaryngology for Head and Neck Surgery at Weill Cornell Medical College at New York Presbyterian Hospital. She received her medical degree from Indiana University School of Medicine and completed her residency training in otolaryngology, head and neck surgery at the University of Cincinnati College of Medicine. Dr. Cerna maintains memberships with the American Board of Otolaryngology, the American Academy of Otolaryngology and Head and Neck Surgery, the American Laryngological, Rhinological, and Otological Society, the American Academy of Sleep Medicine, and the American College of Surgeons. Dr. Asim Roy is the medical director of the Ohio Sleep Medicine Institute. Dr. Roy completed his neurology residency at Georgetown University as chief resident and his sleep and neurophysiology fellowship at the Cleveland Clinic Foundation. He serves on the board of directors for the Committee on Accreditation for Polysomnographic Technologist Education and is a member of the American Academy of Sleep Medicine, American Academy of Neurology, American Medical Association, and Columbus Medical Association. Mike Jacobson is a physician assistant with UC Health in Northern Colorado. He received his undergraduate degree from University of Rochester and his graduate degree in physician assistant studies from George Washington University School of Medicine and Health Sciences. He has been in practice for over 15 years and has additional expertise utilizing advanced modes of non-invasive ventilation for patients with complex respiratory, cardiac, and/or neurological problems. Today's event includes presentations on OSA prevalence and treatment, patient selection and risk stratification, DISE and implant, and post-implant care, followed by a roundtable discussion between the 3 presenters and concluding with audience questions. To begin, we have 4 audience polls that will allow our presenters to customize their presentations for today's audience. Please indicate your specialty on the screen. We'll have a poll coming up on your screen in just a second, which will ask you about your specialty. It should be on your screen now. Select from sleep doctor, advanced practice provider, ENT, sleep tech, or other. Be sure to hit submit. We'll share the results in just a second. I see many people are voting, which we really appreciate, so that today's conversation can be customized to the audience. Okay, let's take a look at the results. They should be coming up. Here we go. Okay, so 44%, the biggest number are sleep techs. We also have 42% as others. We have 8% sleep doctors, 5% advanced practice, and 2% ENTs. Let's go on to the next poll. We are going to ask about what is your familiarity with hypoglossal nerve stimulation, Inspire? Are you very familiar, somewhat familiar, or not familiar? Please click submit so that your response will be included in the total. And I see lots of people are already voting. We can go ahead and close this poll out because actually most people have already voted. And I can see that 67%, the biggest majority, are somewhat familiar. 15% are very familiar, and 18% are not familiar. Let's do another poll. Let's see, this one is, have you referred or implanted any patients for Inspire? This one is a simple yes or no question. Have you referred or implanted any patients for Inspire? Okay, we have already surpassed 50% of folks voting. Excellent. We can go ahead and close out this poll. Looks like we've got a good representation of the audience, which says that 83% have not referred or implanted for Inspire, and 17% of today's audience has referred or implanted for Inspire. And then our final poll to customize today's event, have your patients asked you about Inspire? Yes or no? Okay, just again, a pretty straightforward question. Have your patients asked you about Inspire? Looks like we've almost got half of people voting. We've got more than half of people voting. We can go ahead and close out this poll and take a look at the results. And actually, it looks like it's just about 50-50 for who has, yep, actually, 50-50. Okay, excellent. Well, we all appreciate your audience participation, and I am now thrilled to let Maria Cernat, MD, FACS, present on OSA prevalence and treatment. And Maria, we will be giving the controls to you.
So, moving forward with obstructive sleep apnea. Obstructive sleep apnea is extremely prevalent disorder in the adults, and it's estimated that millions of people are affected by the disorder, meaning the apnea-hypopnea index greater than 5 events per hour. Unfortunately, a lot of people who have obstructive sleep apnea go undiagnosed and untreated. Of people who actually have been diagnosed, there are multiple treatment options that are available, and positive airway pressure being probably one of the most common ones. So untreated and undiagnosed sleep apnea is estimated to have very significant economic and societal costs. It's been suggested that in 2015, untreated and undiagnosed sleep apnea was associated with almost like $150 billion. The costs are not necessarily associated with like health-related, obstructive sleep apnea-related health issues, but there's also workplace accidents. There is a loss of productivity and work absenteeism and motor vehicle accidents. And again, if it comes down to like human life, like how do you put a price on that? And so if we do treat obstructive sleep apnea, we can make significant difference from the societal and economic aspect. So positive airway pressure is the most commonly used treatment to treat obstructive sleep apnea, and it was first introduced in the 1980s. And at that time, it was pretty revolutionary treatment option because it allowed the treatment of sleep apnea without having to use significant or kind of a pretty invasive procedures such as tracheostomies or airway surgery. And the treatment is effective if you use it. Unfortunately, not everybody can stay compliant with the treatment, and anywhere between 40 to 60% of people with sleep apnea continue to use CPAP long-term as prescribed and nightly. So the technology has evolved, and machines and masks have been also modified to try to make it more suitable and to improve compliance of people with sleep apnea. But as you can see, despite of the evolution over the years, over the decade or so, a couple decades, the non-compliance remains still about 30 to 50%. So that creates a problem, and that needs for us to find solutions for those people who are not able to comply with PAP treatment. So current treatment options are oral appliances that are custom made by dentists, or mouthpiece that pull the jaw forward or advance the tongue in order to open up the airway. Those can be effective treatments, but they do have potential side effects such as malocclusion and pain of the jaw. There's also anatomy altering surgeries such as like palatal surgery, base of tongue surgery, even maxillomandibular advancement where you alter the skeletal structure. And again, those carry their own morbidity, and the outcomes are not always as good as desired. So also, there are new pharmacologic treatments that have been currently under research that can potentially improve the like muscle tone and increase the activity. And then there's also like kind of combination of different treatments that could be tried. And hypoglossal nerve stimulation That's been a therapy that's been currently like available commercially and not just in the clinical trials since 2014. So currently in the United States, hypoglossal nerve stimulator device that's produced by Inspire Medical is the only one that's FDA approved and commercially available. And it consists of the implantable pulse generator that gets implanted subcutaneously just below the clavicle. And it's connected to the stimulation lead that gets placed over the distal branches of the hypoglossal nerve. And then there is a breathing sensor lead that's placed between the in the intercostal space. And that allows monitoring the respiratory patterns. So what happens then after the device is implanted, which takes it's an outpatient surgical procedure, patient is allowed to recover, everything heals, and 30 days after surgery, device is activated and patient can use it by activating the therapy with a remote control. After the therapy is activated, the algorithm senses the breathing patterns and it attempts to deliver neurostimulation with each breath by stimulating the hypoglossal nerve and thus opening up the airway. And that happens throughout the entire night, and during the day, the therapy is off. So this therapy can be adjusted to change. You can actually adjust the stimulation to meet the individual patient needs. You can monitor the adherence and compliance through the Inspire Cloud, where you can see how many hours and how many days patients have been using the therapy. And then also provides the report and can also look at the stimulation level and the adjustments. And you can also see how many times a night patient has to pause or not use the therapy. So current indications for the therapy is for adults who are 18 years of age and older, who have been diagnosed with moderate to severe sleep apnea, who have tried positive airway pressure and are unable to tolerate it. And they also need to have proper airway anatomy, and the sleep apnea should be mostly obstructive with less than 25% of the central component. So the therapy was FDA approved after the clinical trial publication in 2014 in New England Journal of Medicine. And since that time, there's been over 100 peer-reviewed publications on this therapy effectiveness. And the clinical trial now has the data that's been published of a 5-year therapy use and effectiveness of the therapy. There's also a Adhere registry where patients get enrolled, and like a real-life registry where patients who have been implanted get enrolled and monitored for therapy use, effectiveness, and compliance. And currently, over 10,000 patients have been implanted worldwide, and the number continues to grow. Compared to like first initial introduction of the therapy, where it was considered experimental by a lot of payers, currently most insurance approve the coverage and consider that the standard of care, and it's also covered by Medicare and also by many VA and military hospitals. So the patient's pathway, that we're going to go through with more details on that. It starts with the patient identification, screening, implant, therapy optimization, and long-term outcomes. And now I'll pass it on to Michael Jacobson to further discuss patient evaluation and screening.
Thank you, Dr. Serna. Let me get the correct monitor here. And hopefully you are seeing my slides. Yes, great. Well, thanks, Dr. Serna. I am a PA in a pulmonology and sleep group, and I think the interesting thing about sleep medicine is there's lots of different disciplines that practice sleep medicine, and you see a good sampling of that here, and a really good kind of team-based approach is really necessary for these patients to be successful. So you see APPs, you see pulmonary groups. Dr. Roy is a neurologist by training. We have an ENT, and these are all the moving parts that we need to have a successful treatment for these patients. So what can I advance my slides? Good. So we'll be talking about finding the right patient who's the right patient? When is it going to be the right time to move to a therapy such as Inspire? And how do we set these patients up for success? How do they know what to expect? And you know, what's going to be the best pathway to success? So we've got that FDA criteria that Dr. Cerna mentioned, and that's very cut and dry. In fact, you know, your AHI is either between 15 and 65 an hour, or it's not. But I think we all know the nuances of medicine and who can really be successful with this are a little bit different, and that's where getting experience and really knowing what to expect, we can help have higher success rates for these patients. So what is CPAP failure? You know, initially that was a little bit nebulous, and now I think we have a better grasp of that, but that is one of the principal criteria for this treatment. It is only for people that are CPAP intolerant. And what we typically use now is what most of us are familiar with Medicare. When you start a patient on CPAP for Medicare, they have to use it for at least 4 hours a night on at least 70% of the nights for at least 1 month out of the first 3. And if they're able to do that, they're going to be able to keep their CPAP and continue using it. And if they're not able to do that, they're going to need to give it back. So we use that same standard when evaluating patients. You know, are they CPAP intolerant? You know, and if they are not able to get at least 4 hours a night on at least 70% of the nights after giving it a legitimate try and trying different masks and trying different settings, then that would meet the definition of intolerance. Medicare would also accept that, you know, simply giving it back after at least a month of use. CPAP failure is defined as still having an AHI over 15 per hour despite proper CPAP usage. I think in practice that's pretty unusual, although every once in a while you might see an AHI that you're not really able to improve. So what are the other considerations? I think there's a lot that goes into this, again, to have success for our patients, to have really good outcomes beyond just that simple FDA criteria. You may notice we talk a lot about the BMI, but that's not actually included in the FDA criteria, but it is one of the major considerations in who we choose for this therapy and in the success rates. The reason that we have a cutoff typically of 32 is because that was what was used in that original STAR trial that Dr. Cerna mentioned, where all of our outcomes and you know, the FDA approval was based on. And so the heavier you are, the less likely this is going to be successful. So originally we would only typically implant people with a BMI of less than 32. Now in certain cases, and including Medicare, you can actually go up to a higher BMI, but we always want to counsel our patients to bring that down. Number one, it makes your sleep apnea better typically, but it also makes this treatment more successful. The other thing that we've come to learn over doing this over 5 years is what are the other things that disrupt sleep beyond sleep apnea? I think we know a lot of patients, you fix their sleep apnea, they get better. They don't have insomnia anymore. They're cured. But there's a lot of patients where there's a lot more nuances. So identifying the other comorbidities, what are the other things that interrupt their sleep? Identifying those from the very beginning and attacking them aggressively from the beginning, again, is going to ensure better success with this treatment. So do they have nocturnal movement? Do they have bad sleep hygiene and they're playing on their phone all night? Is there some kind of uncontrolled psychiatric condition that needs to be addressed first before we can really delve into treating their sleep more? Chronic pain, anything else that's going to interfere, we want to aggressively manage those things as well. So when do we want to, you know, suggest surgery or move these patients on to surgery? Well, I would suggest if your CPAP is a giant tin box that looks like this, we might want you to try CPAP again. Or if it looks like that, or if you keep it in your bag with your Marlboro lights but don't plug it in, it's probably time to try CPAP. So when we talk about CPAP intolerance, we and I mean modern CPAP. Okay, I think we know a lot of people, they maybe failed 5, 10, 15 years ago, and the nature of the technology getting so much better, even in the last 5 years, new masks coming out, a lot of people can be successful, and we really owe that to them with CPAP being the gold standard. If they can do that comfortably, that's what I would like them to do. So I will often ask people, if they haven't worked with me before, if it's been a really long time, to try CPAP again. Maybe different auto-adjusting settings would be better. Maybe BiPAP would be better if their intolerance is really that exhalation. It's also a good time to think about the other treatments that Dr. Cerna mentioned. Would MAD be appropriate for a certain patient? Those aren't requirements. You don't have to try other alternative treatments if you do want to have Inspire or surgery, but it's something to think about. And if that's the only CPAP mask you've ever tried, I might ask you to try something different. Here's some examples of my patients of CPAP downloads that we look at, and I think patients fall into certain groups. Someone that you've been taking care of for a long time, and they're always bad at CPAP. And year after year, they come in and they look like this top download. They try, but they only do an hour or two every night, and every once in a while, they get a fair amount of usage. Is that really enough to derive the full benefit of treating their sleep apnea? Probably not. You zoom out on a different patient here. This is a whole year's worth of data, and they have these months here and there where they use it reasonably consistently, but most of the time they don't. And for those patients, I think we can do better with other treatments. So have you tried other masks? Do you have a modern device? Have you tried settings? If you've tried all those things, and the patient comes in asking about Inspire, or you're looking at alternative treatment, that's probably someone to move on right away if that's what they're interested in. What about someone that's brand new? This is their entire CPAP download, 16 days, and they don't like it. Those patients, I'm going to typically set up the expectation that you try your CPAP for 90 days, okay? Most people we know, they struggle at the beginning, and a lot of them ultimately can be successful with the things I mentioned and coaching, stuff like that. You see this patient, even in the last 3 days here, maybe they don't like it, but you can see signs of improvement. They're starting to get better. So I will ask them to give that a little bit longer before we think about alternative things. We know full improvement, full adaptation could take months and months for some patients to get used to CPAP and really feel better. And what about someone who just had their sleep study, they're coming to you for the first time, and you say, okay, well, you really need CPAP, and they make a horrible face. The treatment with Inspire, even if that is ultimately what may be best for them, it still requires a trial of CPAP. So again, I'm going to tell them, okay, maybe we're going to get there, but you still have to try CPAP at the beginning. Technically, CPAP refusal is allowable, but I don't typically get that a lot, and I wouldn't really want to accept it. The patients really have to invest in their own treatment to be successful. So I'll always set a 90-day expectation, even if they don't want to do it. When you start doing Inspire and people hear about the newest and coolest thing, you're going to get a lot of phone calls and a lot of visits. And what about people who are on CPAP, but, I don't like to travel with it, it's annoying, my wife thinks I look funny. Those are considerations, but from an FDA standpoint, not liking CPAP is different than being intolerant. And so I always coach my patients, if you can use CPAP, if you can sleep well, if you feel good, this is probably the best thing for you to do. And I always like to show everyone their data. Look, you're doing it every night. You're having less than 1 apnea per hour. That's the right treatment for you for now. And so how do we talk to these patients? There's different, centers and different ways to do this. Some people just evaluate the patients and send them out to be treated. Some groups take care of everyone from start to finish. We do all of our evaluation and management, and we have an ENT who does our implants. So how do we set these patients up? The biggest thing we've learned is this is a long pathway, as we showed you, and we want patients to know what to expect. You will have happier patients if you tell them, this is the stepwise things that need to be done. Here's how it's going to go. Here's how long it's going to take, and here's what to expect. And when you do it like that, everyone is much happier, and you run into much fewer hiccups. So I just let everyone know, there's a lot of things. You've got to see me. You've got to have a sleep study. You've got to get your DISE. You've got to do this. You've got to do this. And they say, okay, when they know what to expect. Having a coordinator to guide them through those things is very helpful as well. And I also let them know, this is a good treatment, but it's going to require a lot of engagement and a lot of time, and you've got to be patient, but ultimately you can be successful. You know, today's December 15th, and a lot of people are coming in saying, oh, I really want to get this done before the end of the year, my deductible resets, and that's just not the way it is. Yeah, and so this is just, again, more of that pathway, really the steps involved, getting diagnosed, making sure you meet the criteria, make sure you've tried the right things, and then moving on to the next step. And with that, I will turn it back to Dr. Serna.
All right. So once the patient is identified, the next step would be to proceed with surgery. But before we proceed with surgery, the patients have to undergo what's called drug-induced sleep endoscopy, or DISE. So what is drug-induced sleep endoscopy? Well, it was introduced in 1990s as a way to evaluate patients' airway during sleep. The concept is that when patients are awake and you look at their airway, it's not the same, and it doesn't really give you a good representation of what's happening to them during sleep. And so nasal endoscopy during sleep has been evolving, and that's basically, again, something that we can utilize to understand where the obstruction happens during sleep and maybe provide more targeted treatment. So usually drug-induced sleep endoscopy is performed in a surgical center or outpatient procedure place where you actually have anesthesiologist, because we usually use propofol, and you administer the propofol, you titrate it to get patient to the level of sleep, trying to mimic their natural sleep, even though you have to keep in mind that this is still pharmacologically induced sleep. And then we place flexible laryngoscope through the nose and kind of evaluate each level of the airway while people are asleep. And you can look at the palate, at the base of tongue, at the epiglottis, and see how it collapses during sleep. And so what we're looking for specifically is whether the patients have anterior-posterior collapse at the velopharynx versus do they have complete concentric collapse. So here's an example of what complete anterior-posterior collapse looks like in a patient under sedation, and this is the example of what complete concentric collapse looks like. And patients who are good candidates for neurostimulation device are people who have actually anterior posterior collapse, who do not have this complete concentric collapse. And the reason being is because when the company looked at outcomes of neurostimulation, they found that people who have complete concentric collapse don't have as good response to neurostimulation, and their HI doesn't drop enough. And so that's what they saw, and they included patients in clinical trial who did not have complete concentric collapse, and now they're requiring us to evaluate the patient's airway and exclude those who have complete concentric collapse in order to assure that those patients who will undergo the surgical procedure will be actually responders. So now we'll show you a quick animation of what the implant looks like. And I think
this animation shows how upper airway stimulation works. When the muscles and soft tissues of the throat relax and block the airway, Inspire delivers mild stimulation to the hypoglossal nerve, which controls the muscles and movements of the tongue, stabilizing the airway and improving airflow. Since it's a motor nerve, the stimulation is delivered with very little sensation to the patient. The distal branches of the hypoglossal nerve control two important airway dilator muscles, the genioglossus and geniohyoid. Targeted stimulation to this distal portion of the hypoglossal nerve activates these two muscles, which gently push the tongue forward to open the airway. These sedated endoscopy videos show airway patency in response to stimulation. On the left, stimulation is off, and you can see the airway obstruction at both tongue base and the palate. On the right, the stimulation is delivered during the inspiratory phase of the breathing cycle. This stimulation significantly increases the airway patency at both the tongue base and the palate, creating a multi-level effect.
So that was a nice kind of like overview and animation of what the therapy does. But to go into a little bit more details, so we bring the patient to the operating room and we mark out the 3 incisions. Most recently, we actually started, like some centers are using just 2 incisions. But again, one is in submandibular place, just like, anterior to the submandibular gland. The other one is going to be just in the chest, below the clavicle. And then the 3rd incision is for placement of a respiratory sensor. That is just below, like, inframammary crease. In women, I have modified the incision to actually place the incision not just right on the chest for cosmetic reasons. I kind of put it laterally, and then I tunnel it under the skin and some of the breast tissue to place it above the pectoralis muscle, the device on the pectoralis muscle in this location. But I think that this incision is kind of much more plausible for cosmetic purposes, especially in women. And then also I mark out the neck incision within the crease. And so when it heals cosmetically, you can barely see some of the scarring. The nerve is monitored during the procedure, and we do place NIM electrodes, needles into the genioglossus muscle, which is just on the floor of the mouth, and then also in the lateral part of the tongue that captures diaglossus and hypoglossal muscles. And then we are able to stimulate the nerve and see the response, and thus be able to differentiate which muscles we are actually, or nerve branches we're actually dissecting. So just to give you an overview of what the hypoglossal nerve looks like and what the function is, that's basically a nerve that innervates muscles of the tongue. And there are intrinsic and extrinsic muscles of it, and there are muscles that are changing the shape of the tongue, they're stiffening the tongue, they protrude tongue, they retract tongue. And so what we're trying to differentiate is which branches of the nerve will be stimulating retractor muscles, specifically genioglossus muscles, and also there's a geniohyoid muscle that is innervated by C1 branch that is not a part of hypoglossal nerve, but you also want to identify and include that. And you want to exclude those branches of the nerve during the dissection that actually stimulates diaglossus, so hypoglossus muscles, which are retractor muscles of the tongue. And so this is the anatomy of the nerve. You can see like lateral and medial branches. So you want to identify those medial branches, and those are the protrusive branches of the nerve. And once you identify them, you kind of dissect them out, you separate them, and then you place the cuff. Specifically, that's a stimulation cuff, which has like 3 different electrodes on the nerve itself, on the distal branches, on the medial branches of the nerve, and kind of atraumatically, and leave that in place. So this is what the postoperative incisions look like. Most of the time, patients don't really have much complaints about it, but sometimes you can definitely develop some hypertrophic scarring, or if people tend to keloid, you should be aware of that as well. So the breathing sensor monitors the breathing pattern, and you want to make sure that intraoperatively you have a good respiratory sensor movement and response, and then you want to see those sort of peaks and troughs that represent inhalation, exhalation. And stimulation is going to be initiated just at the start of inhalation and last for for a few seconds, and then the stimulation will be off, and hopefully that will match with exhalation. And so the goal is actually to try to synchronize stimulation with the breathing pattern. And afterwards, after surgery, you bring patients back into the office and you activate the device. And what you're trying to do is to increase the stimulation to the level where you can have unrestricted forward protrusion of the tongue just above the incisors. Overall, morbidity from this procedure is pretty low compared to other surgical procedures that we offer, such as even palatal surgery, maxillomandibular advancement, base of tongue resection. So most people actually don't take much time to recover after surgery. They only take maybe Tylenol, ibuprofen after for maybe a day or 2. And potential complications such as tongue weakness, speech problems, infection, bleeding, pneumothorax, those are very rare complications, and they are encountered less than 1% of the time. There are also some other like minor potential side effects, such as discomfort with at the incision sites, and some tongue abrasions from the after stimulation, rubbing against the teeth. Patients can also have difficulty sleeping and be woken up with the stimulation. But again, those are all very rare and encountered in a very small percentage of patients. So overall, the procedure is pretty safe and well tolerated. And I'll pass it on to Dr. Roy.
Thank you. And can you see my screen? All right. I know we're running short on time, so I'm not going to spend too much time on post-implant care. But it is an important piece. It's probably where majority of the time we're making sure these patients do well over time and make sure they're successful with their treatment. And one of the key elements I want to hit home with on this portion of the talk is that the device is very customizable and it really can cater to each individual. And I think a lot of this comes with time and experience with the device. My first couple years in 2014 to 2017, I really wasn't comfortable with making a lot of changes, and it took me a few years to kind of get more comfortable, and that also came with more volume as well. So therapy optimization and long-term outcomes is kind of where we're going to focus on. Some of the data we have showing long-term outcome is based on the STAR trial data. So now we have, at least 5 years and more now, a few years later, even some data showing the efficacy of the device. So baseline AHI in the STAR trial was around 29, and at 1 year and up to 5 years out, you can see their AHIs have been stable below 10 and close to 5 at 5 years out. Epworth Sleepiness Scale, again, as we all know, most sleep apnea patients aren't super sleepy, but some of them are. Their average Epworth is usually around a 10 or 11 if they are going to be sleepy. And again, you can see normalization of Epworth up to 5 years out with this data. What else we have is Adhere registry, and this is an ongoing registry. As you saw earlier, Dr. Cerna presented that, the goal is to get about 5,000 patients into this registry. I think we're close to 1,400 patients or more than that already. And this is basically looking up to 1 year out post-implant, how are these patients doing? This is a slightly more severe group, in the real world. Now, not in a clinical trial. You can see the AHIs are creeping up to 34 at baseline and up to getting down to almost a level 5 and 7 a year out later. And you can see the Epworth Sleepiness Scale, again, very similar data to the STAR trial, showing efficacy up to a year out with the Adhere registry. So therapy optimization. So one of the key elements is we group patients into two groups, basically a green patient and a yellow patient. And what this basically separates is the green is good. These patients do well, no major concerns. Typically are using the device all night long. Their AHIs are where we would be satisfied, and they're good to go. And we follow them kind of in a typical pattern, a little bit more frequent than a traditional sleep apnea patient on CPAP. But we usually, once they're stable, we'll usually see them twice a year. It's the yellow patients that are the challenging one, and typically it's about 30% of these patients will fall into the yellow pathway. So again, 70% of the patients will be in this green pathway. They're doing great. They're using the device 6, 7, 8 hours a night. No major concerns. Their AHI is normalized. They're symptomatically improved. And again, we usually see them every 6 months. And again, it's just to keep an eye on their compliance, similar to CPAP. We can download that data off the cloud at Inspire Cloud and make sure they're truly adherent to the device. This is the more challenging pool, is the yellow pool. This patient population of about 30% will either not have great tolerability, so they're using the device only a few hours a night, not every night necessarily. They might have success in terms of AHI decrease. And so the question is, what do we do with these patients? And then there's the second group that's just not responding in terms of one of our objective measurements, which is the AHI, and they're just not responding as well as we would hope. So what do we do with those patients? So one of the things is that, especially the group that's not using it all night, every night, is there's probably a comfort issue. And so what are the options to help with comfort? One is to keep the stimulation as low as possible, but again, not too low so it's not efficacious. The second is there's some customization in when do we want the device to turn on. If they wake up in the middle of the night, how long do we want it to pause for? And then the comfort pieces I'm going to dive into in a second here. So if we have a study, a sleep study that we did with the Inspire, and we found that a lower setting was effective, there's no reason to go higher. Similar to CPAP, if we found a pressure of 10 to work, why put them on a pressure of 13? And we know that the higher the voltage, the higher the pressure, the less tolerability on CPAP, the less tolerability with Inspire. There's really no difference there. So it's key to find the optimal setting at the lowest possible therapeutic setting. Now, if we have issues with insomnia, then, which is very common in many of these patients, what can we do to help them get used to turning on this device? One is delaying the start time. One of the goals is to make sure they're asleep by the time the device is turning on. The sensation they feel when they're awake is quite different, because when they're asleep, they typically can sleep through it. It's only when they're awake do they notice the sensation. And so if we can delay their start delay to 45 minutes or 60 minutes, it might allow them to fall asleep, get into a stage 2 sleep, and the device kicks on and they can sleep through it. The second issue is if they pause it in the middle of the night, is it long enough for them to get back to sleep? So there's a lot of customization here that might help them adapt to the device, and you may not need to change any settings on it. It just might be changing the timing of the device. The other customization, which is, I think, a huge learning curve that comes with getting more experience with it, is understanding the electrode configuration. So as you saw in Dr. Cerna's presentation, the cuff has 3 electrodes, and this has a positive, a minus, and a no polarity. And there's variations of how you can configure the cuff to distribute the stimulation to the nerve, either wide, so getting a large portion of the nerve to stimulate, or very little. And so you can really customize how much voltage and how much energy you want to deliver to the nerve. And again, Inspire for me was a huge support team to help me learn some of these techniques as we got more and more patients using the device, because this is a critical element for that 30% group to help them feel more comfortable with the device. Again, this is a great example of how just changing the electrode configuration can make a drastic difference in the upper airway opening. So on the left, you see a positive minus positive electrode configuration, very little opening in the retropalatal region. Their AHI was 40 with this study. You change them to a 0, -0 polarity, and you can see the opening so much better. And you can see the voltage difference. On the left, there's a 2.7 voltage, and yet you would think higher voltage is better, not necessarily. Here on the right, lower voltage, but it's a wider spread of the electricity. You're capturing more of the nerve. You're able to open the airway quite a bit more. Again, a very simple thing like that, and a lower voltage makes it more tolerable sometimes as well. This is a great example. Patients struggling. On the left, you can see on the compliance data here, they're using it 2 hours or so a night at 1.5 voltage, very difficult compliance issues. They're feeling this sensation that's hitting the back of their neck, so they just can't wear it all night. Change the electrode configuration, and now they're able to tolerate it 5, 6 hours a night. So they're doing much, much better. This is one key element to getting them comfortable with the device. That's the first step. The second is efficacy. So it's really to get them using it all night, getting comfortable with it, and then we focus on efficacy. So this can be a process, and setting those expectations are critical because it's not necessarily a quick fix. And again, long-term outcome, this is all ADHERE registry data. 93% of these patients feel satisfied, they like it, and again, most of them are comparing it to their CPAP experience. And again, adherence in the ADHERE registry showing about 5.6 hours per night of usage. Again, majority of these patients are using it, and it's more than 70% of the time. Again, comparing it to some of the national studies that have been out there, like the Apple study and the SAVE trial, we're happy if we can get CPAP to 4 or almost 4 hours a night in these studies. We're well ahead with Inspire in terms of the ADHERE registry data. You can see relatively similar ends across the board here. So again, this is something I think Michael kind of hit on is there's other things beyond sleep apnea in these patients, and it's really important not to hang our hat on one tool here, because sometimes there's other things that are actually the main issue for their sleep, and it may not be tied to their apnea therapy. So, again, positional therapy sometimes very necessary, even with Inspire, as well as sometimes with oral appliance therapy, even with CPAP. Some patients can't do well with their treatment on their back, and so we might have to combine it with positional. Again, comfort measures. We talked about some of the voltage issues and other things that we might need to do. And then again, if they have insomnia, if they have restless legs, if they're still sleepy, can we give them some symptomatic relief that might help them use this treatment, but also improve their sleep quality? And then I think this is a big philosophical question: is the AHI really one of the main outcome that we need to focus on? And again, that's controversial, and again, the data is not out there to say, is that the only target? If they're able to sleep 7 hours and get an AHI of 10, is that better than an AHI of 1 and sleeping 4 hours? So these are things to think about when we're trying to, what are goals of therapy in some of these patients? One of the things I really want to hit home with before I finish here is one of our philosophies is right on day one, and this is where I think Michael also harped on, some patients come in with some preconceived ideas about CPAP or preconceived ideas that they want Inspire immediately. But it's really important to discuss all options. And again, I think one of the future of our field is to phenotype these patients. Can we get better at determining what is the best therapy for them sooner than later? Right now, we still have to follow these kind of protocols and algorithms, but I think we do need to start thinking about how to find a guided approach and be more personalized in our decision making. But again, it's important to discuss everything with these patients up front, because a lot of them will say CPAP and it doesn't work. They're going to not come back because they don't think there's other solutions for them, or were there solutions within CPAP, but it keeps the patient engaged in their treatment, in their disease, and not ignore the disease because one treatment didn't work for them. And I do think it's helped our patient retention, our flow, our relationship with other community docs. It really has helped in terms of expanding our practice profile and become a differentiator, because again, there's not one tool in our toolbox anymore. We have multiple tools. We have pharmacologic therapies, we have oral appliance, we have Inspire, we have other surgical management. So, and sometimes it requires multiple things to do in some of these patients because they're so complicated. So I think it's important to keep that open mind and think about attacking the disease in different ways for each patient. Might be quite different. It's easy to throw a CPAP and do great on an APAP in a home study that shows apnea and they fly. We don't really need to see those patients. It's the more complicated ones that we need to be managing. We're going to switch over to a quick roundtable. I think we just have a couple minutes here to discuss some questions. But thank you for your time and attention, and hopefully you guys gathered some information today. But I think one of the questions I saw, at least in the question poll, is the anatomic considerations when we're deciding sleep apnea management. And Dr. Cerna, do you have any recommendations on what do we want to look for in the airway and the nose, and are there other things to think about?
Thank you for the question. It's actually a very pertinent question. And when it comes to anatomic consideration, so in addition to evaluating for that presence of that complete concentric collapse. There are other factors that we need to keep in mind. Presence of big, large lingual palatal tonsils. So if the patients have like 3+ or 4+ tonsils, I think just starting out with tonsillectomy would be probably the first step, because a lot of times just removing the tonsils will be, if not completely curative, but would be something that I would offer the patients. And then also sometimes when you evaluate the patient's base of tongue, you can actually see presence of large lingual tonsils as well. So even with neurostimulation, sometimes that bulk can potentially be still contributing to the airway obstruction. Sometimes you can also see a floppy epiglottis, which is underappreciated in a lot of cases, but hopefully with neurostimulation, you can actually get that retroflexion of epiglottis corrected as well. When you're asking about the nasal obstruction, well, in general, nasal breathing is advantageous for people who have, in order to avoid having sleep apnea. I think nasal mouth breathing alone, actually one of the factors that contributes to worsening of sleep apnea and increases the airway resistance, because so when we do drug-induced sleep endoscopy, one of the things I look for is the patient mouth breather, or are they breathing through their nose? And just even a little bit of a mouth closure that can be accomplished by the chin strap or even dental appliance might make a huge difference. So that is something needs to be also addressed. And even if you fix the nasal obstruction by doing like septal surgery, you can still have people who are kind of habitual mouth breathers, and that can be potentially the cause of failure of a traditional surgery, sometimes also failure from even oral appliances or CPAP, and then definitely could be a contributing factor to non-responders when it comes to Inspire therapy. So there's also another question that I saw about maxillomandibular advancement and cure, looking for cure. So yes, maxillomandibular advancement can be a great option for correcting the airway and opening up the airway, especially when they have like craniofacial deficiency or abnormalities. And I do offer it to people in the properly selected patients, usually younger people. But when it comes to people who are like, patients who are in their 60s, 70s, 80s, I'm not sure if maxillomandibular surgery, advancement surgery is the best option, because they already have some of the bone loss. They already have, so like non-healing and problems with like, postoperative problems and recovery issues and healing issues can present as a potential complication. So I would probably consider neurostimulation before maxillomandibular advancement in that population, especially since most of those people actually have more of a neuromuscular tone issue. And recovery from neurostimulation, I mean, it takes a couple of days versus maxillomandibular advancement. It takes sometimes weeks, months, and some of the patients actually have permanent residual like numbness or issues moving forward. And also, like in terms of cure with neurostimulation, you can get patients below AHI of 5, and we actually are successful in that quite frequently. So if you consider cure with the therapy use, yes, Inspire definitely, the goal is to get to the cure, but are we always successful? That is actually, I might address my co-speakers to see, like, how do you actually talk to patients about the outcomes? Like, when you talk to patients who come in and say, like, well, how successful is therapy? Like, what do you tell them? Like, how do you set the expectations, and what are the expectations that you usually present?
So, and Michael, you can chime in. One of my first questions is, is this a patient that's not treating their disease adequately right now? And so the expectations is different than someone who is already treating their disease, but it's not changing how they feel, or they're struggling with the treatment, but there's ways to make it work. The second group that's struggling with any treatment and nothing's working, the question is this a effective solution for them? Are they going to be able to tolerate this treatment? Are they going to see success? And again, success is it the AHI, or is it able to treat a disease 7-8 hours a night, even though it's not perfect on the AHI? So I think those are some of the expectations we set. And then, for me, I think explaining what this device means, because some patients come in and Michael, you've mentioned this many times, they don't realize that this is a pacemaker or a device being implanted. They kind of have this, imaginary world that this cures their sleep apnea without anything in them. And so I think those are important discussions to have, because psychologically, some patients may not really want something implanted in them. If they don't realize that that's kind of what this involves, then they might be set up for failure as well. So, and what are your thoughts on that, Mike?
Yeah, no, I agree completely. And so, yeah, we want to be clear, this is a surgery, this is an implant. It takes a lot of steps for it to be successful, setting that up front. To Dr. Cerna's question, we also refer out to an ENT to do our implants, and we want to have everything completely in a row, so it really is a slam dunk by the time they get there. So really setting the expectation of what it involves in the surgery itself. I do often quote a lot of the statistics from the STAR trial, so people know, yeah, this is successful a lot of the time, most of the time. But there is, when we talk about in surgical sleep literature, I think it was one of the slides, what does success mean, right? It means reducing the baseline AHI by at least half and bringing that AHI down under 15 per hour, so into the mild range. And so, I'm frank with patients, we are able to do that the vast majority of the time, but you know what? There's always going to be one or two patients out of 10 where we really cannot reduce them as much as we like. And so people need to know that it's, of course, a surgery is never going to be 100% successful.
Thank you all so much for your informative presentations. I think we're about to end, but Dr. Cerna, did you want to make one last point before we conclude the webinar?
I was going to touch about, there's a couple more questions that came through, and I was just going to quickly touch on those questions, even though I already typed in the answers to them. But to just make a point that the nerve, when you use the therapy, it's a motor nerve, it's not a sensory nerve. And so most of the people do not feel pain or discomfort or vibration. So it's a mild stimulation. You can also adjust the levels of stimulation to make it comfortable. And so the goal is to find that sort of sweet point, like, stimulation, that level that will treat the sleep apnea, but at the same time doesn't provide any discomfort or doesn't wake people up. And then the other question that was brought up is whether we use oral appliance in the patients who are non-responders. So yes, combination therapy, that was also brought up by Dr. Roy, is an option. And so I think, overall, when we're looking at the person who has sleep apnea, and I think this is something that I think we all kind of underappreciate. It shouldn't be just one treatment kind of fit all approach. I mean, we need to look at the people as individual person, and everybody has their own individual sleep apnea, and what works for one person might not necessarily work for the other. And when we, for example, approach treatment of hypertension, we don't just always give the same medication. Sometimes we need a combination of medications or combination of exercise, diet, etc. So when we look at sleep apnea, I think that should be also our mentality. So what would work for this specific patient? Is it going to be just monotherapy with CPAP? Is it going to be CPAP with oral appliance? Is it going to be maybe surgery with CPAP? And then whether it's going to be traditional surgery or then neurostimulation? And then if neurostimulation is not fully effective, is there a combination therapy that could be added? So I think that's something that's evolving, and I think that's going to be still a challenge in terms of trying to diagnose and provide appropriate care to patient and care that people will be compliant with. And I think as a multidisciplinary team, I guess we should be all working together to try to accomplish that goal. So, and thank you very much. Thank you everybody for joining.
Excellent. That is yes, thank you, Dr. Cerna, and to all of our presenters today. I really appreciate it. That was a very informative presentation. Thank you also to Inspire for sponsoring this free event for attendees. Today's webinar is being recorded, so in the follow-up email that you'll receive tomorrow, we'll include a link to the recording and a reminder that you can access a PDF of the slide deck in the handout section on your control panel. And we'd appreciate it if you take the course evaluation, which will appear on your screen after the webinar ends. If you have additional questions, we will send the ones that came through before and during the event to Inspire. And you can also email inspire_medical education@inspiresleep.com. You can email Sleep Review at webinars@medcore.com with comments, questions, and future webinar suggestions. Visit us at www.sleepreviewmag.com, and thank you for participating in the Sleep Review webinar.